My husband said to me, don't worry, it's a bit like a best man's speech at a wedding, that the audience are going to be with you and they're going to laugh at your jokes. It's not that they're going to heckle you from the back. So I'm hoping that you're on that page. And as Warren has said, the title is Cold Toast. You'll be hearing a little bit about that shortly. But the how and the why of patient and public involvement in kidney care. So, think kidneys. The first thing I want to say is really the context of kidney care in this country. So we have a number of issues in firstly trying to find out how many people have got some form of kidney damage. And I've been involved with a couple of studies, big studies, where we've looked at GP records to try and see what percentage of the adult population has got some form of kidney disease. Now, we think it's about 6% of the population have got stages of what we call 3 to 5 kidney disease, the kidney disease stage that really matters. We've got to keep an eye on people who've got stages 3 to 5. But one of the issues is that we think there are about 6% of people, but GPs have only really recorded about 4.2% of the population, of the adult population. So actually we've got a missing million, and it's a bit like it was with diabetes many years ago. We're still trying to find people who've got kidney damage, because unless we know who they are, we can't look after them very well. Now, stage 5 kidney disease is about when people need to potentially have dialysis or a kidney transplant, and we've got about 60,000 people in this country with kidney disease that warrant renal replacement therapy, as it's called. So although there are large numbers of people who've got some form of kidney damage, there are much smaller numbers of people who then require to have dialysis or a transplant. So the next film is going to show what it's like to have kidney disease. And this is one of a suite of films that's been made by Barts Health, and it involves people who've got the condition talking about what it's like.
My first reaction when I heard that I got renal failure was just, I heard white noise. That's all I heard.
First of all, it's fear, and then you think, oh no, this can't be possible. You have a doubt, it's like, me, really? Me with kidney failure? It's not possible.
I didn't believe it. I was young, I was only 23, at work, was keeping quite fit, going running, all these types of things, and all of a sudden, somebody told me there was something wrong with my kidneys.
Total shock. I didn't know anybody that had kidney disease. I didn't know if there was any form of medication that would help me. And I thought, am I going to die?
One of my initial thoughts was, who'd want a guy with kidney failure? Who would want a guy with a tube hanging out of his stomach or a fistula in his arm? I really put myself down in those days. I thought, I'm probably never going to have a kid. I'm probably never going to hold a proper job. Although I'll let you know that these things hadn't happened yet, but already in my mind, I'd thought I couldn't do them already. I already put doubt in myself.
When I had the right information, when I felt that I'd had time to absorb it all, actually I was in a much better situation than I thought I was going to be. And the fear started to dissipate. I started to think, well, actually, I can get on top of this. I can manage it. I can go to work. I can do the things that I did before.
I managed to find somebody. I managed to get married. I managed to do all the social things that I managed to do, go to cinema, go to the gym, go to parties, go on roller coasters, just do the normal things in life and still enjoy things.
I started thinking that living with renal disease is going to be a challenge, but I could cope with it.
I tend to lead a healthier life. I'm conscious of what I eat. I like to walk with my daughters. I like to cycle with my wife. I tend to do the healthier things in life now, and I'm grateful for the second chance that I've got.
Not long after I was transplanted, I went out to Turkey for 10 days to paraglide out there, which was just fantastic. And, so you can really carry on with these things.
Going through the trauma of dialysis and the transplant and complications with that. When things are going well, you truly are thankful.
Here I am, 61, still here, having had a completely full life and, married life for 30 odd years, now had 2 children, able to go travelling abroad, even now on dialysis I still do that. So yes, I've had a very full life.
You do have your off days, but they're for a limited time, and you have to get on. Life still carries on, and that's what I do.
I think everybody will still feel scared. I think that's still a natural reaction. But I would like to encourage people that once you get on top of that fear, that you can really live a very, very normal life and a very enjoyable, full life. That's the important thing. And I would hope people would be able to do that.
So now a little bit about what I'm going to talk about in this lecture. So you've seen, first of all, that the overall title is around patient and public involvement, and I'll explain about involvement in a minute. But the first thing, I'm afraid, is about terminology, and we've heard a lot of terminology about people with conditions. How are they called? Are they service users? Are they people? Are they citizens? Whatever. Now, I'm using the term patient here today and carer because I've asked a lot of people over the time, are you happy with the word patient? And a lot of people with kidney disease say, yes, I'm very happy with the word patient. So I'm going to use that term today, but of course other people use other terms, particularly service user. So generally what my talk is going to be about is involving people, firstly in their care, so in other words, helping them to manage their condition themselves. And we're going to be asking how you can do that and why you might do that. Secondly, about involving people in teaching and learning, education, again the how and the why. And thirdly, about research, so the how and the why of involving people with the kidney condition or carers in those 3 things. So I'm going to introduce you now to the involvement ladder, and some of you might have seen that before, but you can see from the reference it's something that's come from the late 1960s. But it's this idea that you have different rungs of a ladder, and at the bottom of the ladder it's where patients are seen as passive consumers. So in other words, it might be how you imagine healthcare in the 1950s, and some of you will have been watching Call the Midwife. So things happen to people and they have no say in what happens next. So they're very passive in the relationship. The second thing is about giving information. So we're very big, aren't we, on giving patient leaflets, giving information to people. But sometimes it's not a two-way process. You give information and actually patients are told what's happening but actually have no influence further from that. The next rung of the ladder is consultation, so a bit more involvement. Patients are asked what they think, but have limited influence. And there's been a critique, really, of the friends and family test, in that, and some of you will know, you go into hospital, you're asked, what do you think of this ward? Would you recommend this hospital to your friends and family? You fill in the form, but then what happens? Nobody ever knows, really, what recommendations then translate into improving care. The next rung of the ladder is about participation. So this is where it gets a little bit more of a partnership in care. So maybe self-management, people have shared decisions, that sort of thing. So patients make suggestions and influence outcomes. Sharing power, where it's an equal partnership. And the final rung is where patients or carers have full control of their decision making. So you may know now that some local authorities are giving people healthcare budgets so that they're able to manage their care and decide where the money should go. So I'm going to refer to the involvement ladder a little bit during the talk. Now, here's somebody looking not dissimilar to me. You can see 35 years ago. And I've got my good friend Shane in the audience who was there with me at that time. Some of you will recognise the uniform from the Royal London. It's changed a little bit over those 35 years. But the point of the slide is when we were doing, or when I was doing my basic training, this idea of involving people in care was never part of it. So the next slide is showing moving on a couple of years and me going to St Bartholomew's Hospital to do the renal nursing course. And I managed to find this in the garage. My husband will know that I've been searching for this thing. I eventually found it and said, look, I knew that it was there. And there's a lot of text inside that explains, and I know you won't be able to read that, but explains the philosophy of the care at that time. And I'm just going to read you this little bit in red here. It says, much emphasis is placed on teaching the patient to understand and manage his condition. So at that time, that was quite a contemporary thing. And for those of you who are familiar with dialysis, you will know at that time there was home dialysis where people had their kidney machines at home. And part of the role was, as nurses and healthcare practitioners, to involve people in their care. And when I left St Bartholomew's, I then went to King's as the home dialysis sister, and so there were patients on home dialysis, kidney machines in the community, and also on peritoneal dialysis. So it was at that point I knew that's what I wanted to do. It's always about involvement, it's always about partnership, it's about working with people to improve their health. Now things have moved on an awful lot. So this slide is showing what we do now at London South Bank University in terms of involvement, in terms of involving people who've got conditions. So maybe it's a physical condition, a mental health condition. How are people who've got conditions involved in the day-to-day running of the university? So I've given some examples there. So we've got a couple of people in the audience I know who are involved in recruiting student nurses. So they're involved in the selection process, and some people are also involved in recruiting staff. We've got people with conditions who are involved in curriculum planning. They say, well, this is what I'd like the student nurses to learn about. They're going to have some input into what student nurses learn. The next thing is learning and teaching. In the classroom, we invite people who've got, invite people who've got kidney disease to come and talk to students about what it's like, and I'll return to that a little bit later. Similarly with assessment, we've got service users who are involved in assessing students. And finally, we've got people with conditions being involved in research. Now, personally, and I know I've bent Warren's ear about this a couple of times before, personally, I think we could still go further. And I think, because it's about partnership working in the NHS, on day one of any, let's say, nursing course or whatever type of course, occupational therapy, whatever it is, that we should say this is partnership working, and we've got somebody who needs the service of occupational therapy, somebody who's got kidney disease, to stand at the front and say, this is a partnership, and the service users are going to be with you on your journey. So that's where I'd like to take it. We're probably a little way off from that just yet. But that just gives you a flavour of how things have moved on over the past 35 years. Now, you're probably wondering, what's the cold toast story? Here's the story.
Hello, my name's Brian. I've been a patient for 40 years now. This year is my 40th anniversary. I first began dialysing in 2008-2009, and one of my earlier experiences was that I had a morning shift, so I was dialysing from 8 o'clock until 12 o'clock, and I would normally get into the hospital at about 7 o'clock, I suppose, wait for half an hour. I was then called into the dialysis unit and connected to the machines. And one of the things that we really looked forward to when we were on the morning shift was a hot cup of tea and some hot buttered toast. Now, the young healthcare assistant who brought the tea and toast around would deliver the tea and toast in a particular order. Now, in the unit, there were probably about 24, 25 patients. If you were at the beginning of her round, then you received a nice hot cup of tea and some lovely warm buttered toast. If you were at the end of her round, you received a lukewarm cup of tea and a piece of toast that was damp and a little bit like cardboard and floppy. And given the importance it was to have a first morning cup of tea and something to eat, it was a real disappointment if you were at the end of the queue to receive your tea and toast. So I suggested a couple of times actually that perhaps there were ways around for improving this. Why not, for example, prepare 5 pieces of toast, deliver those, then go and prepare 5 more. And I wrote a little note to this effect, but nothing happened. And so for the whole of the period that I was dialysing, the tea and toast routine did not change. When I received my transplant, my concerns, because I had raised a number of concerns in the hospital, were brought to the attention of a nurse consultant. And as I began to feel better as a result of the transplant, she approached me and said she was aware that I'd raised some concerns about improving the overall condition of kidney patients, and would I be willing to become involved in setting up a patient forum, the precise objective of which was to improve the conditions for kidney patients. And I said, yes, I'd love to do that. And that's how we started the patient forum.
So just before I move on to the next slide, I'd like to thank Brian very much, who's in the audience, and also Breda, who's the nurse consultant he refers to. So clearly, Breda, you had that can-do attitude. What Brian's referring to is involving a group of patients in service improvement, making things better for other people who've got kidney disease. And that's been very, very successful at Bart's, and the sorts of issues, I mean, Brian, maybe you should speak later about it, but the sorts of issues, it's the issue of transport, it's the issue of the cold toast, it's all sorts of issues that affect people, what matters to people. And as healthcare professionals, we're sometimes too focused on the dialysis machine or on the potassium or the phosphate or whatever it is. So that very nicely illustrates about how involving people can make differences to care. So what I'm going to talk about now is involving people in their own care, in self-management. And my interest with this started, as you can see, really with my doctorate, and my supervisor, Ros Breyer, is here, so it's lovely to see you, Ros. And this doctoral study was really asking people who had early kidney disease, people who were at risk of kidney disease because they had diabetes, how much did they know about managing the condition themselves? And you'll see from the quote there, a very typical quote, I interviewed people, I did not realise how important the monitoring of the diabetes and also the blood pressure was for kidney damage. Now that was a very important message at that time, so let's say that's 10 or so years ago, and a lot's happened since, but actually that's where my interest first started. I thought, well, if people themselves who are at high risk, people with diabetes, they're at high risk of kidney disease, if they don't know how to manage themselves, then we've got a bit of an issue. So the doctoral study that I did developed a package with patients and then tested it to see would it make a difference. Now the results weren't terribly conclusive at that time, but actually it was one of the first studies that looked at managing self-management of early or mild to moderate chronic kidney disease. And then that continued, as you can see, 2010 to 2012. I was part of a Health Foundation funded study that was managed by Kidney Research UK. And this moved it on a little bit more because we had a patient and carer group who were involved in every part of the process. This was a quality improvement project. And you can see there that booklet was written by patients to help you look after your kidneys. And that's really, really critical when you're writing patient education materials, because it's got to come from the people themselves. And this has now developed, my interest has developed even further, and I'm really privileged to be part of this team, and my lovely colleague Helen is here, and Breda, part of the East London Community Kidney Service. So you can see it's a relatively new service, and you'll see where education fits in. But in order to see where education fits in, I just need to give you a couple of pointers. So the first thing is that I've said already that we don't actually know who everybody is who's got kidney disease. So the first part of this service is to search into GP databases to see who's got reduced kidney function. And then you alert GPs to say, of those people who've got reduced kidney function, who's got progressive disease? So then an alert is sent to GPs for them to review the patients. The second thing then is the GPs will look and see, well, okay, does this person need referral? So what happens is the patients who potentially need referral are referred to what we call an e-clinic. So the patient doesn't actually go to the clinic. They're referred electronically. The kidney doctor reviews the patient, and then there's some decision made about that person's care. So it might be that, yes, indeed, they need to come up to see the kidney doctor. It might be that they have education, or it might be that no intervention is needed. So the third part of it, and this is where I'm involved with Helen, is that we have patient education, and we're involved in one-to-one, well, Helen's involved with one-to-one education and me with group education for patients and relatives. And we've developed a number of resources to help people self-manage their condition. And you'll see an example of a couple of them there. So it looks quite simplistic, I know, but we have a very diverse community in East London. A lot of people might not have English as their first language, but we employed a graphic designer to make the images, which would then be used in one-to-one and group education. And that bigger picture on the right is what's called a conversation map. So in other words, when you talk to people about their condition, it's not showing them a load of slides, and this was Helen's fabulous idea. It's a conversation rather than saying, do this, do that. And the next slide shows Helen. It doesn't quite look as if you're having a conversation. It looks like you're talking to the wall. I thought that after we'd taken the picture. But actually, there are a group of patients there. and this was taken a couple of weeks ago when we were in Waltham Forest. And it's really talking to people about how they can look after themselves. So if we go back to the one before, talking about what your kidney number is. So we're encouraging people, when you go to your GP, do you know what your kidney function is? And of course, we invariably ask people, do you know what your kidney number is? No, they say, I've never been told. Do you know what your blood pressure is? Might be, no, not quite sure. So I think there's a message for clinicians there as well, isn't it? We need to involve people in their care in order that they can self-manage. So that's the map. So that's a bit of the how. And really now what I'm coming on to is the why. Have we got evidence that involving people in their care actually makes a difference? So we've got I'm sorry for those of you who are maybe not so interested in the research, but this, and I know that's very small, but what that's saying is that the effectiveness of self-management programs in early stages of kidney disease cannot be conclusively ascertained, and further research is required. So we don't really know yet whether early self-management makes a difference. However, it's desirable that individuals with long-term kidney disease are supported to effectively self-manage day-to-day aspects of their health. So we know it's a good thing. We don't think we're doing harm, but actually we don't know yet that it makes a difference in terms of behaviour change. Now, what we've done in East London is ask people, have you done anything differently as attending education? And we've got these things here. Yes, I try to eat less salt, exercise more, trying to give up smoking. Yes, I cut out the foods that were high in salt. I stopped taking the Nurofen. So just not to alarm you all here, but that's a particular poisonous drug for people who've got kidney problems. And if we look at the conversation maps, have we got evidence for that? I'm sorry to say we don't have that either. So conversation maps hold the potential to improve health outcomes, but there's a need to develop further studies. So really what we can conclude from that is self-management's a good thing, but we can't really say that it makes a difference. So before we leave involving people in care, I just want to talk about one national study that's going on at the moment called Transforming Participation in Kidney Disease. It's funded by NHS England, and the idea is that there's an intervention work stream which is developed by patients and clinicians, and these interventions will then be rolled out to a number of renal units across the UK. Now, I'm not going to talk a lot about that, but the point I'm trying to make here is that there's been a study done last year looking at patient experience of kidney care, and you'll see about 8,000 patients were asked their opinion. And this next table is going to show how patients rate the care that they had. Now, I'm sorry that's probably quite small, but there are 12 themes there, and the themes you can see are, how does the renal unit treat you? What about, do you have good access to the team? What about support, communication, all those things? Now, the point of this slide is if you look at sharing decisions, which is more than halfway down, that's the thing that scores the least. So the point of this is that some clinicians get partnership working, but other clinicians don't. And so we've got a lot of work to do, I feel, with fellow staff, let's say. Do they really understand partnership working? And there's quite an interesting debate about renal nurses. Do renal nurses come into renal because they want to have partnership working, or do they come in because they're interested in the technology? So I think as renal nurses we have to do a bit of soul searching with that, because really the aim of care, isn't it, is to have that partnership. So now I'm going to move on to education, so involvement in education. And I'm just going to talk a little bit about this in terms of what I do in terms of practice. But I strongly believe that whenever I'm talking to people about kidney disease, what it's like to have kidney disease, all of those things, that you have to have the people who've got that condition with you. And I really, really try to do that, particularly with student nurses, so they have exposure to people who've got the condition, with specialist nurses who are sitting up on the back row, and also within e-learning module, which I'll come on to in a moment. And you may remember Richard, I was going to say the hand glider, is that right? The paraglider who's in the audience. And Richard, and also Shahid, I can't see him just for the moment now, who's there, and Linda and Brian, people who come and talk to the nurses about what it's like to have kidney disease. And that picture there, that's where Richard dialyses at home. And I think it's so important that there's time set aside so student nurses and nurses undertaking the renal course have time to talk to people about what it's like, and more importantly, how care can be improved. Now with e-learning, I've been involved in developing some e-learning modules, a foundation module for everybody who's new to kidney care, and also some subsequent e-learning modules. So the next slide is showing how we can involve people in e-learning.
The strangest thing for me was trying to establish the target weight. Unfortunately, it was at least 4 kilos over Anne's normal weight. Now, I know she'd had an operation and she'd been sitting around, and maybe there was some extra weight put on, but it wasn't 4 kilos. And despite discussing it with the staff quite extensively at various occasions, because she was continuing to have the water was settling on her chest at night, so she was wheezing and coughing, and trying to explain to them that I thought that the main problem was that she wasn't having enough fluid taken off. But of course I'm a layman, so I didn't, new to dialysis, so I think I wasn't really taking that seriously at that stage.
So what I'm trying to illustrate there is that the people who are closest to those who've got the kidney problem, they know what needs to be done. But as he said, actually I wasn't taking that seriously. So that's a very important message, isn't it, for people who are learning about care, that actually it's always a partnership, and you absolutely have to listen to the person and listen to family members. So it's quite difficult to evaluate the impact of involving people in education, and I don't know how easy that is to read, but these are some post-it notes from student nurses following education sessions where patients and the public have been involved. So I'm going to have to read them out because I'm not sure you can see them either, but hearing the patient perspective helped me to understand their point of view. It was good to hear things from the patient carer, excellent and informative. We were provided with an insight into what it's like being a full-time carer, how the illness affected both of their lives. The time spent listening to her was useful because she made me realise sometimes the little things like asking the patient how they are and their family can be useful. So that particular insight is really, really critical, I think, particularly for student nurses. And because of that, what I've tried to do, I have this textbook that's actually going to be in its 5th edition next year. But in the 4th edition, I thought, well, actually, we need to have the patient and carer voice in this textbook. So a number of people in the audience, again, have contributed to this chapter. And I'm going to read you an extract to really illustrate the point of how messages from patients and carers can then go out to nurses to say, try and think of these things to make care better. So this is entitled, My Thoughts to You as Nurses. Kidney disease is with the patient and their families for the rest of their lives, and each one has their own individual circumstances. Learn as much as you can about them as individuals and their particular condition, and you will help transform how they cope with their disease. As a patient on hospital-based dialysis, it's very difficult to comment if things are not right, as you feel very vulnerable. Criticism, however constructive, is not always well received, and therefore things that could be improved go unchanged because of lack of trust. Being confident that those who care for you really know you will develop a sense of trust that will enable concerns to be raised and addressed. And there's some bullet points here to the staff. In the early days of diagnosis and dialysis, patients may feel very unwell, frightened, depressed that their life is over. There may be anxieties about their employment, finances, housing, family and so on, which may affect their overall health. Spend time to get to know your patients as well as possible, understanding their home and family circumstances, their fears and concerns. Understand what they enjoy and what they can do, not what they cannot. And it goes on like that because it's a piece directly to nurses to say, listen to patients, involve the family, because then you can really improve the quality of life of people who've got that condition. Now, taking this even further, we have a group who's affiliated with the Health and Social Care within South Bank, and they're a drama group, as you can see, called Third Thought. It's very tricky to say that, the memo. Third Thought, and you can see carefully examined in well-prepared drama by actors over 60 years old. And I've been in discussion with them because I feel that if they came and were able to talk to people on dialysis about what it was like on dialysis, then it's possible that through their lens, through the dramatic lens, if you like, they could then convey to nurses and other staff what it's really like. And I was a bit nervous of this because I thought, well, maybe the people themselves could convey that message. But the Third Thought company came back to me and said, yes, but we're actors, we're able to convey the message, we're able to talk to people, see what it's like, and then convey the message in a different way. And actually, I mean, we haven't quite got going with it yet, but I think it's a very interesting project, and the role of arts and creative arts within education, I think, is something we haven't used enough of before. And finally, in this section, I just wanted to talk about the journal that I edit, the Journal of Renal Care. I involve people in that journal by, I've had editorials of people who've got the condition writing about what it's like, and we've had papers from people about their experiences of dialysis and transplantation, but actually I want to take it a step further. And I want to take this from the BMJ, and some of you may know that they've had a patient editor being appointed, and what's written on their website is it sees partnering with patients, their families, carers and support communities and the public as an ethical imperative. And I absolutely agree with that. Why have a journal where people write about how they could improve care through research and quality improvement, and yet that message doesn't then go out to patients and carers? So I'd be looking to appoint a patient editor for the journal. And I think the role would be maybe for some papers that are critical for patients, the findings that are critical, there would be like a summary, what we call a lay summary, so written in people language, and also the chance for the patient editor to disseminate information, let's say through the kidney patient associations. So I'm really keen on that, and I'm hoping to do that in the next couple of months. So we heard before a little bit about what's the evidence for self-management, and now we need to look at what's the evidence for involving people in education. Again, it's a bit tricky. So we've got the things, you can see the two references there, systematic reviews, service user involvement is valued, the experience can be transformative, and I seem to have missed off a little speech mark there, sorry. Greater insight into the service user perspective, greater reality to the education programme. So that's what the students are saying about the input of the patients and carers. But what we're missing at the moment is the evidence that by listening to patients and carers, did the nurses' behaviour actually change? Did they do things in a better way? So clearly we need something more about evaluation of education and patient involvement. So the final section now is about research, involving people in research. And a number of my colleagues in the audience and patients and carers who've been involved in research are here too. So within the school we have a kidney research user group. Now this came with me from City University, and the aim of the group is to involve people who've got a kidney problem, or carers of people who've got a kidney problem, and to help well, not help, to be involved in identifying research topics, so what needs to be researched, actually being part of the research process in terms of grant application, in terms of developing research proposals, in terms of actually interviewing as part of the research process, and then disseminating the research to kidney patient groups. And I was very pleased. We had some money just a month or so ago, and some of you who are in the audience attended. And you can see us here. We had some money from Kidney Research UK for a patient information research day. So this idea, our aim of the day, was to come together and say, what are the research priorities for patients? And also, if we're going to involve people in research, how do we do that better? And Michael here, he's a member of our group, so he himself has got a kidney condition, and he's talking here about why it's important for patients to be involved in research. And that's probably a bit small for you, it's a bit small for me as well, but it's really, I mean, what he's written in the bullet point here is it's important for him because it's his future. Research is his future. It's important for him because we can raise awareness of kidney disease. It's important for him because we can provide solutions to issues that directly affect us. And something that's quite clear is Kidney Research UK identify research priorities, and quite often the focus is on cure. Give me a cure for my kidney condition. But actually, as we all know, there's all this money going into cure, and I believe it has to also be about care, making things better on a day-to-day basis. So this is some meeting notes that came out of that meeting a few weeks ago, and there was a whole theme around how treatment affects me. What I've highlighted is this social isolation of therapies, especially home dialysis. Now, I met a lady on that day. I've been in this field for whatever it is, 35 years, but I'd never thought of that. I'd never thought of that. And we promote home therapy. We say home first, peritoneal dialysis at home or home hemodialysis, and I'd never thought of that. So how important it is that people who've got the condition say, this is what we need to research. What's it like, or are you socially isolated if you have home dialysis? So that's just a very small example, but a very important one for patients. Now, it's been an absolute privilege to be part of this project that I'm now going to describe to you. And again, my colleagues in the audience, a number of whom are in this slide here. So the aim of the project was to really look to see what's the experience of older people when they're making a dialysis decision. So in other words, what's the experience of older people in the shared decision-making process. And I'm going to flip back to the previous slide, because just to explain to you, so there's me here, Karen, who's a nurse consultant from East Kent, Breda, who I've mentioned to you before, is actually missing, she's taking the photo, and then everybody else who's here are people who've got experience of kidney disease, either themselves or they're caring for somebody who's got the condition. And this is important because this hasn't really been done in kidney care very much before, but patients and carers were involved in every part of the research process. So getting the money in the first place, developing the proposal, I'll come back to the training in a minute, designing interview questions. So what they were doing was they were saying, what do we need to ask other patients about the decision that they made when they needed dialysis? So they were involved in the interview questions. The patients and carers undertook the interviews, they then analysed the research data and then are involved in disseminating and presenting the findings, and we've published the paper there. The reason receiving training is highlighted there is that we've had some critics of this. I'm going to say this publicly now, but we've tried to get research funding for a similar project using the same process, and critics have said that's no good. There's bias in that methodology because patients are interviewing other patients. Aren't you going to get bias? What about bias if I was interviewing? I've been in this 35 years. I bring my own baggage with me as well. And if you do qualitative research in a good way, you've got some insight into what, let's say, what baggage you're bringing with you. So I would refute those criticisms. And the other criticism is, well, have you trained people well enough? Have they really had research training in order to make this a good process? And we had lots and lots of training, practice interviews, people were confident. We had a psychologist there who would support people if it was psychologically difficult. So So I'd just like you to bear that in mind. Oh no, before that, we had a commendation for it. So that's very important to say. So okay, we've had some critics, but we've had some that think it's a good idea. And I'm now going to show you a film from the patient and carer perspective.
This research project came about through sort of discussion that I had with a couple of colleagues, one at Barts Health, one at South Bank University. What we wanted to do was to have a different approach to research and involve patients and carers in the research process itself and getting them to actually do the interviews for the participants. When we started the project, we initially sort of met as a group in Kent, and the Barts Health met as a group in London.
Nice to see you. No.
They actually were very keen and very enthusiastic when I approached them about getting involved in the research. So it wasn't a challenge to recruit them individuals, and they've been absolutely amazing.
We've taken two completely different groups of people who'd never met before, two completely different health trusts, brought them together, and they've just formed this amazing relationship between each other. And I think they've just got this huge energy and enthusiasm.
The key purpose of the project was to assess the decision-making process for elderly patients as to whether or not they were going to opt for haemodialysis, peritoneal dialysis, or, as in the case of some patients, conservative care.
What was really quite interesting about the project was that we were going to have a lot of independence about how that project was going to be designed, what kind of questions were going to be asked.
There was a lot of time and effort invested before we actually went ahead live with the project, if you like. There were a number of mock interviews that were done. Once we got the questions how we felt that we wanted them.
I found every interviewee to be relaxed. Once we told them who we were and did the introductions.
I introduced myself as I'm also a fellow hemodialysis patient. That immediately broke the apathy. The patient opened. You can see straight away, like a smile came, as if it's good to be on dialysis.
So I think once they understood my history, they felt quite comfortable talking to me about their history.
There's so much of knowledge still in these elder people. And they're just waiting to find time to share, to talk to somebody.
The impression I got is they wanted to tell you about it, and they wanted to give you as much information as they could. They understood it was a research project themselves, and a lot of them wanted to do the best to try and help that research.
I think it was absolutely worthwhile having patients and carers interviewing other people, because I think whenever you're a clinician or a researcher interviewing patients and carers, because you haven't been through it yourself, it's putting yourself in the other person's shoes. And if you've been in those shoes already, then you're able to have a much better relationship and maybe have much more rich research data from the interviewees because you've been there yourself.
You get that totally unbiased opinion, and you get a true, honest account of what it actually does feel like to be a dialysis patient. I think that's what's so powerful about it, is the patients themselves. And if we can get more patients involved in how we deliver our services, but also research, then I think it can only be a good thing.
And I think what we've learned from this project, we'll be able to hopefully scale up in other areas, so that other teams working in universities or in hospitals can indeed replicate the similar co-produced research.
Patients are the heart of everything that we do, and we talk about person-centred care. Patients are people. As soon as they come through the door, we change them into patients, but actually they're people. As healthcare professionals, we need to do the best by them, but the only way we can find out what they really need is to ask them and to involve them in that process.
So I hope actually that patients will become more and more involved in decisions made not only about them but about the quality of their care in general. So I think it's very important that where patients can be involved, then they are encouraged to be involved.
I'd recommend it to anyone that with any condition, a sample of some sort, a blood sample, a urine sample, filling in a questionnaire, doing whatever, it doesn't hurt, it doesn't take much time. I think back to what things were like when I was first diagnosed with my condition and how things were. I think things have improved a huge amount. We progressed by research, and so get involved.
So we're coming to the end, but as it's been with the other sections, we just need to finish this section on thinking, does it make a difference? Do we know that there's any evidence by involving people in the research process? What impact does it have? And I'm sorry to say you're going to guess the answer to this again, aren't you? But from a person perspective, from the person who's got the condition, then people who are involved in research report that they feel empowered, they feel valued by taking part. Some people say they've gained confidence and life skills, increased awareness of their condition. From the other side, clinicians and researchers, better understanding and insight into the research area and a sort of rapport and respect within the community. We've mentioned this already, there's something about training, and generally it's been found that patients and the public are expected to maybe take part without proper training and how they could do that. And sometimes there's the issue about feeling overburdened, and we're very, very conscious of that when we involve people in research, particularly if people aren't feeling well. And clinicians and researchers reported difficulties in incorporating involvement in meaningful ways, and I certainly know colleagues who struggle a bit with that. So here we are again. We need more research to really understand the impact of involving patients and carers in the research process, and then the systematic reviews. I don't want to leave before really talking about involvement in service improvement. Now, I'm sorry if some of you are maybe not familiar with this, but there's a difference between what makes a research project and what makes a service improvement project. And what this poster is showing you, and I know you won't be able to read it, but I'm involved in a national quality improvement project at the moment, which is to do with identifying people at risk of progressive chronic kidney disease. And we have a patient and carer or patient group that's part of that project. And without going into a lot of detail, and I know you won't be able to see, but we've got sort of 3 case studies here. This gentleman here who's got a lot of expertise in business and has been involved in writing a business case for the intervention, which is where labs identify people at risk of kidney disease. This person here is talking about how important it is for kidney disease to be identified early. And this lady here is a GP and also somebody on dialysis, so she's been able to give a dual perspective. But the point of the slide is that really involving patients and carers in making things better, improving your service, is really critical. And I'm now going to give a promotion to two of my colleagues' book, who are sitting in the audience, Leslie and Elaine, because I think was it chapter 2? I can't quite remember. But there was a chapter in that book on involving patients and carers in service improvement. So hot off the press. A good plug for the book. So I've come to pretty much the end of what I'm going to talk about. I've got a couple of final slides because I'm going to leave the last couple of slides with the patients and carers themselves. But Elaine, who we've just heard from with the book, is now going to see, are there any comments or questions from tweets that have come in?
There are. So Kath Evans, who works a lot in involving children in their care, has asked whether you think there's a role for family and possibly friends of service users in research rather than just patients.
Yes, I mean, we've certainly seen within our projects we have carers. Carers is a bit of a funny word, but family members, people who are involved with patients. I absolutely think there's a role. I can't really comment on children because I know that, not that I have any involvement with children in these areas, but I imagine once you've thought of all the ethical issues and once you've, thought about safeguarding and all of those things, then I imagine that's okay, and I don't know if anybody wants to comment. I don't have any experience of that really.
Qualitative data collection in this population or either any other chronic illness population. In work I did, as you are aware of, about coping in young people with CKD, I was the principal investigator and the one who was asking the questions. And I did have a little bit of a struggle in the first place about knowing my role, but I think that's absolutely right, that you can get really good, rich data being a patient and being a researcher. Just knowing that there is a fine line, I think is absolutely absolutely key that side of research is also promoted, because patients know their disease and they can know the course of the disease. And also in a younger population, they're still going through it, and having been through it at a young age, born with it, gone through it through, up until now and the rest of my life, I know exactly what these kids will go through. So it does make good research to be a patient researcher.
Thank you.
That seems to be the reaction on Twitter. People, I tweeted that you said you couldn't progress with the bid because you were using services as the researchers collect the data, and there's astonishment on Twitter that you've had that experience.
That's very interesting. I'm not going to name the funder, but okay. Yes. No, absolutely not. Okay, so we've got 5 minutes. I think if I just show my final couple of slides, and then if we might have a chance then for a couple of questions. So it's the what's next, and I'm not sure that that's terribly clear. There's a lot of writing there, but if I just highlight a couple of things within self-management, within education and research. So I think in terms of people being involved in their care, we've got to really sustain self-management and spread self-management interventions for other parts of the country. As far as I know, I can count on one hand the number of kidney nurses who work in the community and are involved in educating people about kidney disease and, more importantly, facilitating self-management. So that's got to spread. That's just madness, isn't it? And we haven't talked about costs, but to give you an idea, a self-management intervention, somebody being looked after in primary care, we're talking probably £200 or £300, whereas dialysis, haemodialysis or peritoneal dialysis every year is about £25,000. So it's madness not to invest money in prevention. So that's that. The second thing is maybe the interventions we've got at the moment are all paper-based or they're one-to-one, and we know we've got to really get to young people, and I strongly believe we've got to use social media. We've got to use apps and social media to really try and enhance self-management. The second thing is about involving people in education. I think there's much more scope within e-learning to involve patients. I'm Deputy Vice President of the British Renal Society, and we're developing a number of e-learning modules, one of them on vascular access, for those who know about that. So it involves accessing blood for haemodialysis. And we're going to have patient stories within that e-learning module, because we've got people on the group who are patients who are going to develop the content with us. So that's really important. And a bit of a promotion, really. We have this lived experience network showcase in December. So that's part of LSBU, but it's really showcasing what we do within the university in terms of involving people in education. So that's about making it wider. Finally, to research. We want to replicate the process that I've just described in other research projects, and we've got another bid in to do with experience of carers, which the idea has come from somebody in the audience, and I'm heading up a new research group within LSBU, and we've got a new centre for research that's been developed and a number of groups within that. So we've got a long-term conditions and ageing group, which kidney disease will be part of it, but I can't see Calvin now, but my colleague Calvin is interested in stroke, for example. We've got people who are interested in orthopaedics, anyway, a whole load of different things. But I think it's about scaling up always, isn't it? And somebody mentioned just now about learning together. So my final slides, last two slides, are about what matters to me. So in other words, what matters to people. And I've got a bit of a story about this, because I started talking to people who've got the kidney disease, or look after people who've got kidney disease. What matters to you? And I wanted them to send me pictures of what matters to them. And this has got a great story, because I was lucky enough to be able to speak to this lady about it. And she said, well, the big thing for me is we're given an awful lot of information, which is good, but if we've got to make a critical decision, there's not enough time to decide. And choosing about dialysis is one of those things. And she said a couple of weeks ago, she went to, I think it was a friend or family member she was accompanying to a consultation. And the person, the medic, had to give some bad news, very bad news. And what the medic did, which is an exemplary, in my opinion, practice, he said to her, I'm going to give some bad news now, and I'm going to give you the news, but then what I'd like you to do is come back later today, and we're going to spend half an hour talking about what your options are. So it's saying, actually, we're giving you some time. We can't give the bad news and say, bye then, go and sort that out for yourself. So she said it was really great because they had lunch together, they spoke about, what could happen, what questions to ask, and then the consultant had given half an hour in the afternoon for the people who he'd given the bad news to in the morning. And actually that's a really good way of working. And we've got to think, well, some people can change practice, can't they? They can change their consultation times, they can change their clinics, but that's really, really important. So that's just illustrating what can be done. And I've now got a number of slides, and some of you in the audience will recognise yourselves, but people holding up what matters to them. And as we're looking through them, I want you to think, okay, what matters to those people, and what can I do as a clinician to make that better? Oh, it's a bit small. Can you read it? It says honesty and clarity, being able to continue working, quality of life. Honest information about my condition, genuine treatment expectations. So a lot of people recognise this person. Patient leadership works. Somebody else you recognise. Research and patient involvement. Improved communication between patients and healthcare professionals. Now my next slide features somebody we've already seen, and this person didn't just send me one slide, but sent me a whole montage, which I'm now going to show you. Oh, I'm not sure you can read it. Understand my kidney health through training and education. Comprehensive, balanced information. Right information, right time, don't overload me. Right choice of dialysis for me. Advantages of home dialysis, not looking so happy there. And least happy here. What matters to me is positive and encouraging staff. So I'd like you to, we're going to finish now, but remember what those people have done and see if you can think about changing practice in the future. Thank you.
Thank you, Nikki. I know, like you, judging from the round of applause you've sustained, that colleagues in the audience really enjoyed that. Lots of thought-provoking content. Nikki's happy to take a few questions.
Hi. They're trying to involve the doctors more with your outcome of your kidney problems. Just say basically like that. Obviously, there's other names for it. My kidney failed. My doctor didn't know anything, so obviously he sent me to the next best thing, the hospital. But at the moment, there's a scheme going through to save. It comes down to money again. The cooperation is the paperwork side goes to your doctors, and they then decide how bad you are. This is from the doctor, and then obviously they refer your conditioning, what you do. Now, I went down with kidney failure. 6 years I've had my kidney, and now it's failing. But hey, I'm not going to give up. But the thing is, I was really worried about the treatment because I used to just have blood test after blood test, and that's what I'm trying to get at. The doctors don't seem to have the information that the senior people from the hospitals want them to know. So I'm saying to my doctor, why don't you come along to a big conference? I've got to mention the NKF, sorry, because they do marvellous work as well as yourselves. And they'd be surprised what they talk about and what they'd learn. Sorry, that's just a brief I'm very concerned that now my doctor's going to look after me more in depth. Mm-hmm. And I've had quite a few scary moments.
Yes, I think that's such a good point. And this is, I think what you're talking about is GPs not having specialist knowledge. Exactly. And I think there's so many issues there. The first thing, I've worked with GPs probably for a good 10 years now, and they always say kidney is never high on their agenda. And we've got to try and make it high by maybe badging it as something else, maybe as part of cardiovascular diseases, they get interested in it then. So that's the one problem that we've got. The second thing is they have so many things that they've got to be specialist in. So that's another thing. Something I've learned is that maybe we've never been very good at the relationship between the primary care, the GPs and practice nurses, and the people in the hospital. And for years, those of you who've worked in renal will know, we locked ourselves in the dialysis unit. We shut the door and we never went out. And I really, really believe we've got to go out. We've got to have a good relationship with primary care. And the East London Community Kidney Service that I mentioned, I've been interviewing some GPs about how they think about that project, what they think about, about the project. And what they've said is that because they're now getting good feedback from the kidney doctors about the patients, it's all remotely, they feel they've got a better relationship. And I think that better relationship will then mean better care for you, because they get it. They get kidney disease. And I'm sorry that's a very long answer, but it's such an important it's such an important point.
Hi Nikki, thank you very much indeed for your talk. Is there a case, do you think, for uniting the various kidney voices? Because we have NKF, we have BKPA, we have KRUK, and presumably a host of others as well. And do you think if we want to promote kidneys and kidney concern and chronic kidney disease, whether there's a better way of doing that?
Mm-hmm. Yes, I mean, what Brian's highlighted again is, you're absolutely right. We have, I'm sure it's like a lot of specialties, you have lots of different groups who are all trying to give the same message but doing it in a slightly different way. And I absolutely believe, why don't we come together? But you know as well as I do, there's all the politics, all the issues around money, and we don't seem to be able, do we, to have a cohesive voice. And if there's more of you together, you're always stronger. Not stronger and stable, but some other thing. So yeah, I mean, I'm with you on that, but actually making it happen is always a bit tricky.
Okay, can I just offer Nikki a huge vote of thanks from all of us. I know I've learned a great deal this evening. It's been great to hear Professor Nicola Thomas's great inaugural lecture. Thank you, Nikki.
Thank you.